staircase to your right, which will exit onto Colton Road, the muster point for the inquiry. Please follow these instructions unless advised otherwise by a fire marshal, and if in doubt, follow the green emergency exit signs. Do take a moment to familiarise yourself with our hearing suite etiquette. This can be found on the hearing suite TV screens now. There is a cafe on the ground floor selling hot drinks and snacks, but we kindly request that you only consume water in the hearing suite. You can help yourself to water in glasses, which you can find in the kitchen next to our reception desk. Inquiry staff are wearing orange lanyards. Please approach them if you require assistance. Please ensure that your phones, laptops and any electronic devices are on silent mode. Device screens may be captured on the broadcast during wide shots of the hearing suite. All attendees are kindly asked to stand when the inquiry chair enters and leaves the hearing room. A member of the inquiry team will inform you when to stand. Please remain at your seats until the chair and witnesses have left the room. Thank you for your attention. The hearing will start in a few moments.
Now, good morning everybody, and welcome back to the first of 2 days' hearings in which we welcome back Dr. Ashley Croft to respond to questions submitted by co-participants following his report and appearance at the inquiry in Dundee in July 2023. I'd like to thank Dr. Croft for the preparation of his supplementary report in which he addresses the questions which have been collated by theme. In a few moments, I'll invite Inquiry Counsel Stuart Gale, KC, to make an opening statement, in the course of which he will set out the timings for the submission of any Rule 9 requests that arise over the course of today and tomorrow. I would ask all legal representatives to take note of the timings and adhere to them assiduously. Before we begin, may I remind you of some practical matters which apply to all the hearings we're holding, starting today and ending on 2nd October. Transcripts of our hearings will be published on the inquiry's website, along with witness statements and documents. Any directions or orders, including restriction orders that I have made or will make in the future, will also be published on the inquiry website. If I make any specific restriction orders, I will notify those at the hearing on the day. I may choose to protect third-party information for reasons of confidentiality by redacting statements or stopping the hearings if third parties are named. Finally, may I remind you that the inquiry proceedings are, as ever, broadcast on the inquiry's YouTube channel and recorded to be watched later. Video cameras are located at the rear and sides of the hearing room and face those speaking. You should be aware that members of the public attending our hearings may be captured occasionally on wide-angle or room overview camera shots. I'd now like to hand over to Mr. Gale, QC. Mr. Gale.
Thank you, my lord. Good morning, everybody. Good morning, Dr. Croft.
Good morning.
By way of introduction, can I say that core participants will be aware that the purpose of our hearings today and tomorrow is to hear further from Dr. Croft, who presented his original report and amplified its contents in his oral presentation at the University of Dundee on the 26th and 27th of July 2023. Core participants were invited to submit questions for Dr. Croft based on that original report and his presentation, and many have done so, and we are grateful to you for doing so. Those questions were organised into 8 generalised topics, and I thank particularly Paula Collar of the inquiry's legal team for the work she put into that exercise. Dr. Croft then prepared a supplementary report dated the 28th of July of this year. The reference to that is SCI-DCR and then 506. There is an erratum to that supplementary report which has been circulated to core participants, and that is a similar reference, but 507. The supplementary report and the erratum have been circulated to core participants, and questions under our Rule 9 procedure have now been submitted for Dr. Croft's consideration. The presentation today and tomorrow will follow the numbering and lettering of the topics in the supplementary report. I will deal with topics 1 to 4, or A to D, as they are in Dr. Croft's report. My learned junior, Mr. Edwards, will deal with topics 5 to 8, E to H. We have set aside today and tomorrow morning for seeking Dr. Croft's views on the matters put to us and agreed by us under the Rule 9 procedure to which I have just referred. We do not intend to take Dr. Croft to all parts of his supplementary report, which has obviously been available for some time now to core participants, although it may be necessary in order to set questions in context to have regard to that supplementary report. Core participants can, if they so wish, put to us Rule 9 questions in accordance with the procedure set out as Dr. Croft is giving his evidence today and tomorrow morning. If it turns out that any question is premature, in that Dr. Croft subsequently deals with the subject matter of that question after it has been submitted, then that question can be withdrawn or amended accordingly. We would ask that questions are formulated as accurately as possible and submitted to us as early as possible in order to facilitate consideration of them. All such questions must be submitted before 12:30 p.m. tomorrow, the 23rd of September. That deadline, as the Lord has indicated, will be strictly adhered to. All such questions that are allowed will be put to Dr. Croft tomorrow afternoon. There is one matter I wish to make clear at the outset today, lest there be any misunderstanding. Dr. Croft's reports and the evidence given in amplification thereof are but part of the expert scientific medical evidence that this inquiry is considering, and it will continue to consider in arriving at its conclusions on the scientific and medical background to SARS-CoV-2. In accordance with our Minute of Understanding with the UK COVID inquiry, this exercise will include consideration of the relevant scientific medical evidence adduced to that inquiry. Lord, that's all I have to say in introduction.
Very good. Thank you. Okay.
Good morning again, Dr. Croft.
Good morning, Mr. Campbell. Good morning, my lord.
Now, I would like to divide, if I can, the issues that I want to discuss with you into three separate sections. The first section I would like to ask you about is the contents and reasons for referring to them of what is contained in Annex 5 to your supplementary report. And for clarification, those comments and passages are from extracts from a memoir published by Dr. Anders Tegnell, who was the state epidemiologist in Sweden between 2013 and 2022. And he was also the head of FHM, I won't attempt to pronounce it in Swedish, which was Sweden's public health agency during the pandemic. The memoir is, I think I can manage the title of the memoir, it's De Andere Weg, and it's translated as The Different Way. And you have provided us with some extracts from that. Once we have looked at that, I would like then to look with you at a paper that you have produced for us, which is from the International Journal of Forecasting, and published in 2022. It is by Professors Ioannidis, Cripps, and Tanner, who are respectively professors from Stanford, Sydney, and Northwestern universities. And I would like to then go through some of the points that are raised in that. Once we have done that, I will look, if I may, at the precise questions that have been asked of you since the publication of your supplementary report. And there may be opportunity and need to amplify some of the questions that have been posed for our consideration, but that is the section that I intend to deal with. As I've said, I will deal with areas within sections A to D inclusive. Mr. Edwards will deal with E to H inclusive. So with that introduction, Professor, can I refer you to Annex 5 of your report, which is at page 123 of your report as numbered. And these are extracts from Dr. Tegnell's memoir. Before I go to any of it in detail, could I just ask you why it was that you thought it would be useful that we should have regard to this memoir and its contents?
Thank you, Mr. Gale. I felt it would be useful because, as the title implies, and the title I think is a play on words between the name Anders, Andrew, the title is in fact German, the other way. This is an exposition of a different approach to the containment of the pandemic that was adopted in Britain and in most other countries. And clearly this gentleman, Professor Tegnell, I don't know him, I've never met him, but he was very experienced at the time he confronted the pandemic, and he stuck to his position, which was the principle of voluntary action as opposed to the implementation of coercive measures. These are words he uses. And so since we're coming from a position where we were experiencing coercive measures, I felt it was reasonable to, and perhaps illuminating, to look at what was a different approach to see if, with the benefit of hindsight, our approach could have been modified, could have been different, or whether we, the chair, of course, would consider that the British approach was still reasonable in all the circumstances.
Now, I'm sure you are aware, Dr. Croft, that Dr. Tegnell will be providing us with his evidence on Wednesday and Thursday in the company of Professor Sir Ashley Bloomfield from
Yes.
New Zealand.
Yes, I wasn't aware of that when I put it in the annex. And
No.
I put it as an annex because I didn't want it to impose it as part of the main supplementary report. It was simply there if the inquiry chose to take any notice of it.
Yes. There are, I think, having read through the extracts that you have provided, a number of occasions in which the approach that Dr. Tegnell indicates that was taken in Sweden is in accordance or agrees with some of the comments that you have made in your original report, your oral presentation, and your subsequent report.
Yeah.
Can we begin by looking at the extracts, if I may, Dr. Croft, and begin by setting the context as Dr. Tegnell does. And the first comment, the first extract is from page 31 of his book. And it reflects on discussions that he had with other Scandinavian epidemiologists in February 2020, so at the very beginning of the pandemic. And he reflects there on, as I read it, the question of how he considered that it would be possible to force 1 million Swedish citizens into quarantine were there to be a lockdown of the sort that was perhaps being thought about. And he indicates that he was of the view that that was out of the question for several reasons. Poses one, that the system would break down completely, and it poses the question, who would pay their salaries if that was done? And the other point that is perhaps of some significance is that as a representative and as indeed the head of FHM, they had to think about what he terms the big picture, both epidemiological factors and the consequences of any action taken. Can I just pause there, if I may, Dr. Croft? You've made the point on a number of occasions in your presentations to us that as a public health practitioner, one needs to take into account not merely the scientific basis of proposed action, but also other factors. Does that accord with what you read there with in what Dr. Tegnell says?
Yes, it does. And I suspect early on he was already worrying about schools. And a bit later on, we might come to that. He tells us how he'd recently written a paper about school closures with some colleagues, perhaps the same colleagues. School closures as a potential means for slowing respiratory epidemics. And they'd found, apparently, that it had no impact at all on slowing respiratory epidemics. So already he's starting from a position of, shall we say, informed caution, is how I would interpret that preamble there.
Yeah. Again, looking at context, one of the other areas that's perhaps of some significance is that he draws attention to the fact that Sweden had what is referred to as the Protection Against Infection Act, which provides that enforcement measures can only be taken against individuals who are explicitly verified to be infected, and not preemptively against entire groups of people. Can I have your comment on that?
Well, I think I'd have to look at the exact wording of the Act. Perhaps he's paraphrasing the wording, but
Yes.
In public health, we do have to take enforcement measures all the time, for example, against food handlers who may be infected with salmonella. The enforcement measure that's enshrined in law is that they have to have 2 consecutive stool samples that are negative for salmonella or whatever the organism might be, taken at least 24 hours apart. Once they've had those 2 consecutive samples, they can return to work. So there's a simple example of enforcement action. Again, mind you, that's it's not exactly comparable because they're known to be infected. I've recently been asked to advise about a school in Ireland, a nursery in Ireland, where this situation arose where there was an E. coli outbreak. E. coli is a diarrheal agent, and the nursery had to be closed. And so the children attending that school couldn't attend the school, and they had to give, even though they weren't necessarily infected, they had to provide 2 consecutive samples that were negative for E. coli. So there's a case, I think, where children who were not infected and staff members who were not known to be infected were nevertheless denied attendance at their school and at their place of work under the enforcement powers that the Irish public health authorities have. So I'd be surprised if Dr. Anders' statement should be taken entirely as it's read here. I'm sure there are exceptions to that rule, but it may be that on a mass national scale that's a principle that can't that has to be enshrined, by which the state as a whole couldn't take enforcement measures on a national scale without there being definite evidence of infection in individuals.
Well, we will no doubt hear from Dr. Tegnell on Wednesday and get the background to that.
Yeah.
But what he goes on to say is that Swedish law thus provides for proportionality of risk and action, and as such, intervention in case of low risk should be low threshold. Now, can I just ask for your comment on that? I appreciate that I'm asking you to comment on what somebody else is saying, but what do you take from that?
Well, that seems to be self-evidently common sense. Low risk, low threshold. There's a risk, I suppose, of asteroids or coming from space and wiping out towns, but the risk is so low that one wouldn't necessarily factor that into ordinary public health planning. Other risks are more foreseeable and require public health action. One of them might be, for example, the risk of injury from road traffic crashes, which over the course of time has led to public health action in the form of seatbelt wearing. Yeah, so the risk appreciation is essential to sensible public health advice giving.
Thank you. The final point that Dr. Tegnell makes in that section is that he believed that the people of Sweden would naturally act responsibly and endeavour to take care of these things themselves. And he says, which proved to be the case. Now, I suppose we could get into very interesting questions of comparative sociology and whatever on that. However, from your perspective as an epidemiologist and a public health expert, do you feel that is a reasonable approach, and a reasonable approach to take? And would it have been a reasonable approach to have taken in the UK, and in particular in Scotland?
Yes, I think so. It presupposes that people have access to reliable information quickly, and nowadays everybody does have access to, pretty much everybody, to information quickly through the internet and phones, and so therefore, provided the information is dependable, then one can assume that people will be well informed and would potentially be able to take decisions in respect of their own health.
Yes. We go to the next section in the next extract that you have from Dr. Takenall's memoir, and that is with I think a side heading of deliberations and planning in early March 2020. So again, at the very start of the pandemic. And he says there that the aim was to reduce the spread of the virus to avoid too many people falling sick at the same time. The most obvious way of doing this was to minimize contact between people, always the first step when dealing with a pandemic. The more people stay at home, the less contact they have with one another. And he goes on to say that this was a matter of implementing the pandemic plan in full, obviously the Swedish plan, and included a list of non-medical measures. Many of them were already well established and documented, such as social distancing and disinfecting one's hands. We did not know exactly how effective they were, but there was a general consensus among medical researchers on their importance. When it came to other measures, we knew less. That remains true to this day. And this, just to put that in context, this memoir was published, I think, in February of this year. Limiting large gatherings of people seemed logical once we knew how the virus spread. Yet there was hardly any research on precisely how restricting gatherings could prevent the spread of infection. Now, I've read that all in detail to you, Doctor, and I would ask you to reflect on what is said there and consider how it stands with what you have already said in your presentations to this inquiry.
Yes, I think we are conveying the same message, myself and Dr. Takenall. I can't see that I'm at variance with him in any of what you just read out, Mr. Gale. So far it all seems to me to be sensible and science-based.
And if I can put it this way to you, Doctor, if you had been in a position of giving advice to any decision maker at the outset of the pandemic, is this the sort of advice that you would have been giving?
Yes.
I think we see from what Dr. Takenall says that in looking at non-medical measures, he says that many were already well established and documented, and he refers to social distancing and disinfecting one's hands. Does that accord with your recollection?
Yes, if I may just refer back to my report, which has a section, what did we know at the start of the pandemic?
Yes.
So here we are. So yes, this is page 54 of my original report, and here we are, scientific knowledge pre-pandemic. Frequent hand washing can reduce transmission. Respiratory virus spread can be reduced by hygienic measures. This was all knowledge that was supported by randomized controlled trials. Implementing barriers to transmission such as isolation and hygienic measures such as wearing masks, gloves and gowns can be effective in containing respiratory virus epidemics or in hospital wards. Again, that's supported by randomized controlled trial evidence. So yes, although Dr. Takenall doesn't specifically mention randomized controlled trials, I think that's implicit in his approach. That's what he means by evidence. He means good scientific evidence derived from trials.
So do you see a correlation between what Dr. Takenall is saying and your approach, and I'll put it simply in general terms, of relying on evidence-based medicine?
Yes, and of course, what neither I nor Dr. Taylor are expressing a private view. We're just simply distilling what is available in the public domain in terms of good quality science. We're simply interpreting the knowledge base for the benefit of those whom we are advising. In my case, the inquiry. In his case, the Swedish government.
Yes. Could I just ask you, Dr. Croft, just about the comment that he makes about other measures, obviously referring to non-medical measures, non-medical interventions, and he says that we, as reflecting the Swedish FHM's position, knew less, and he says that remains true to this day. He goes on to refer specifically to restricting large group gatherings. However, if one just takes the generality of what he says in that first sentence, of other measures we knew less,
yes.
is that something that chimes with your views on the matter?
Yes, and the science, of course, will have there'll be gaps in the knowledge base, and it's a responsible public health physician would identify the gaps as well as the certainties or the relative certainties, and this is what Dr. Tegnell is alluding to here, the other measures which were not so well supported by science, or not at all supported by science in some cases. He doesn't spell them out, but we can infer that's what he's referring to.
Okay. Could I ask you now to look at, within the same section, but under the subheading of retirement and nursing homes,
Yes.
What he says there. First of all, he identifies those within retirement and nursing homes as the most vulnerable members of our society. And the homes themselves were informed by the hygiene officers of the relevant healthcare services about the level of protection that would apply to them, and which protective equipment their staff should use. He goes on to say, in Sweden there are many workers involved in looking after the elderly, sick, and providing nursing care in hospitals. For all intents and purposes, these caregivers all belonged to the same category. The recommendations for hospitals were largely the same as for retirement and nursing homes. Now, this is something we will come onto in some of the questions that have been directly posed to you.
Yes.
But this, to a certain extent, presages that question. Again, can you, first of all, take us through one or two of the points there? You will, I'm sure, agree that retirement and nursing homes contain some of the most vulnerable in society, so far as a pandemic is concerned.
Yes, as regards this particular pandemic, because the virus especially targeted or was especially dangerous in the very old, particularly people aged over 85, and the very sick, meaning those with certain underlying conditions, and also people with immune compromise. And so therefore, a lot of those very seriously at-risk individuals would be in retirement or nursing homes. So they'd be vulnerable from the outset. And the nature of the environment in which they lived gave an extra layer of vulnerability, because these were poorly ventilated, these are generally poorly ventilated indoor spaces. And in my original report, I highlighted that the risk of COVID transmission is enhanced in these spaces. So they're vulnerable to start with, and then they had this extra risk of the domestic environment in which they found themselves. So again, it was foreseeable that they would be at particularly high risk of acquiring severe infection during this particular pandemic. Other pandemics have been more dangerous for younger age groups.
Yes.
The Spanish flu pandemic,
Yes.
median age of death was 28.
28, I think,
28, yes. But this for here, the median age of death was about 80. And so they were the ones who really needed very significant levels of care and protection from the outset.
Looking at it from the point of view of those working in nursing homes and retirement homes, as he puts it, he does say that for all intents and purposes, these caregivers all belong to the same category, and I think that's, he's saying, using that in relation to other care settings, such as hospitals and the equivalent of GP surgeries. And he says that the recommendations for hospitals were largely the same as for retirement and nursing homes. Do you see that as being an area where you might slightly differ from him?
Well, there will be groups of healthcare workers in hospitals who will be especially at risk of acquiring this particular virus, and those who are undertaking procedures that involve in aerosols being generated would be at especially high risk. Generally, staff in healthcare in nursing homes wouldn't be undertaking those kind of high-tech procedures, but nevertheless they'd be at risk of they're in intimate contact with sick residents, and so therefore they have a potential for acquiring infection that is very high.
Yes.
So it's reasonable to consider them as all broadly having more or less the same level of risk, but with some outliers in both directions.
I think you've used there an expression which we've seen in one of the questions, at least, that's been posed for you, and that's intimate care.
Yes.
Can you just indicate what you understand by intimate care?
Well, in residential homes and nursing homes, the staff will in the case of many residents, have to help them with their activities of daily living, which are dressing, washing, eating, and so this brings them into close physical proximity. They may even be physically touching the individual, and when a pathogen is being spread through the air, that will inevitably introduce the risk of disease acquisition. So in an ideal world, everyone would stay 2 meters apart when a pandemic is on of this kind, but that's not always possible for individuals who have to have other human beings come up close to them to help them just survive.
I think you've asked that, and it's probably my fault because I put it in this context.
Yes.
You've answered that in relation to care. Excuse me. In relation in relation to care homes and what Dr. Tegnell refers to as retirement homes. But I think one of the questions that has been put to you, and we'll come to it directly in due course, is those who are providing that level of care, either to relatives or indeed where they are caregivers providing care within the community. Would that same comment, would your same comments apply there?
So, Mr. you mean people in the family environment who are providing care? Oh, yes, certainly, yes. Yeah. Yes. Although, if the family unit was locked down, the level of risk would be less, would it not? Because the nature of care homes is that people are coming in and out all the time. The carers have to live out. Generally, they come in by public transport. So there's a higher level. There will be a higher level of risk. Under those circumstances, a family can, to some extent, isolate within a social bubble. So the absolute level of risk is going to be less, but there will be still some risk.
Can I move on to just ask you a few questions about testing, as referred to by Dr. Tegnell? He says at page 46, as you reproduce it, testing all patients and employees in retirement homes and hospitals who were exhibiting symptoms was the top priority for the FHM, but it was not possible everywhere, and he indicates that there was, and perhaps inevitably would be, a shortage of tests. And he goes on to say that we had to set some strict priorities. Many of those who wished to be tested were turned away. Our primary aim was not to test a lot, but to do so where it made the greatest sense. Quality over quantity had long been my mantra, regardless of the testing capacity. Now, can we consider that in the context of an area that this inquiry is directed particularly to consider, and that is the discharge of patients from hospitals into care homes with the intention of freeing up beds within hospitals. The indication from what as I read Dr. Tegnell saying, is that where patients in retirement homes and hospitals who were exhibiting the symptoms was the top priority. So if one looks at that in the general sense, would you agree that testing patients prior to discharge into care homes from hospitals would have been a top priority, or should have been a top priority?
Well, yes, I would agree. And the reason is that they potentially were being discharged into a seething cauldron of potential infection, which is what a nursing home would be under these circumstances, by which they would go in and introduce the infection, which would then rapidly spread in that ideal environment.
You describe a care home as a seething cauldron of
potential infection.
Potential infection.
Yes.
Could you just explain why you use those words? Because those words might seem to be very critical. Could you explain why you use them?
Well, because as I just said a moment ago, Mr. Gale, the nature of a care home, along with a cruise ship or an aeroplane, is that it's a poorly ventilated indoor space. So for this particular type of pathogen, the substrate is there for it to spread between people who are in that environment. And furthermore, the people occupying a nursing home, unlike an aeroplane, are going to be vulnerable anyway because they're generally very old, and therefore their immune systems have just become compromised because they're being very old. So they'll be vulnerable. They may also have comorbidities. And then finally, they will be in contact with staff members, often in direct physical contact several times a day, and the nature of that intimate contact will potentially cause them to acquire the pathogen. So it's potentially, any nursing home potentially could become a seething cauldron of infection. And indeed, these outbreaks, not simply of respiratory virus, but of other infections such as diarrheal infections, often occur in nursing homes for exactly that reason, that they are on knife edge of having several kinds of outbreaks, just by the nature of the sort of establishments they are.
I think it's perhaps important to stress what you've just said at the end of that comment.
Yes.
That it's the nature of the sort of institution they are. Yes. There's not, as it were, a criticism of the way in which any particular care home or care homes in general are operated.
Not at all. Indeed, I might have mentioned this last time. I actually live next door to a care home. We live in Wolverhampton, and our house is semi-detached. The other bit of the building is a care home, and they had no cases of COVID-19 at all during the pandemic, during the height of it. And we spoke to the owner, and it's quite small, and she was very strict about all kinds of aspects of infection control, and particularly she paid for the staff to come in by taxi rather than by public transport. So even though at any moment had the potential for there to be an outbreak. She didn't have any cases. But that was exceptional, and you couldn't hope for that level of rigour in the larger care homes with the best of intentions.
Yes. Thank you. As you anticipated in our introduction, Dr. Croft, there is a passage in Dr. Tegnall's memoir about school closures.
Yes.
Oh, yes. There are a couple of things that I'd like to take from you, having looked at that section. Dr. Tegnall comments that children, or that there was no indication that children could be or were super spreaders of the infection, and they appeared neither to become infected to a particular high degree nor to infect others in turn. Yes. He goes on, we conceded that things might be different for secondary school pupils. So by inference, he's talking about younger pupils in those first comments. Yeah. And in light of this, we and the school authorities discussed whether we might reasonably ask them to switch to remote learning. Now, just, well, actually, can I go on?
Yes.
Because it's clarified in the next paragraph. Unlike primary school pupils, children in the upper years of secondary school could become severely ill. Education experts were of the opinion that they could be asked to learn from home. For these classes, we advocated distance learning to the government. Now, again, and we'll come to this specifically in due course, in relation to some of the comments you've made about younger, well, children and young people acquiring COVID-19. Do those comments by Dr. Tegnall, again, do they chime with your views that you've expressed in relation to the severity that younger people might experience if they were to contract COVID?
Yes, I can't immediately put my hand on what I've said originally.
We'll come to it.
Oh, thank you very much. This is an area where I try not to express my private views, but simply to distill what is the consensus at the time in the publications which I would consider to be expressing ground truth, which are the main medical textbooks. And they, from memory, they considered this question and consider that children might be super spreaders, but my feeling is that latterly that has been no longer features prominently in what the textbooks are saying. They consider that children just generally represent a low risk of disease severity, and I think that's completely accepted. And so therefore children, because they're not going to be seriously ill and they're not going to be coughing profusely, they won't be able to spread the virus efficiently, and so therefore won't be the focus of major infection spread. So yes. So children, I believe that initially there was, with all the points we're discussing, initially the knowledge was zero, but quite quickly the knowledge evolved on the basis of empirical observations, and children who initially were thought to be perhaps a focus of rapid and efficient spread were gradually deemed to be less likely to act in that way.
I suppose this reflects a slight difficulty, if I can put it, for somebody such as yourself as a public health expert and epidemiologist, that there will inevitably and always be cases, and we've heard of them in this inquiry, where children have acquired very severe COVID and have long-lasting effects from that acquisition.
Yes.
Now, I just want to be clear that there may have been some concern that, put bluntly, you were being somewhat cavalier in ignoring those children who were affected. From your perspective, is that something that you would always have regard to?
Of course, yes. With every infectious agent, there is always a spectrum of severity, and it's to some extent it can be predicted as to what level of severity an individual will present with, but it isn't always predictable, and there will be outliers of all kinds in all groups. So we've heard of 95-year-old individuals acquiring COVID and recovering and going on to live to 99. And equally, we have heard at the other end of the spectrum of seemingly healthy young children acquiring COVID and developing very, very severe infection, seemingly without particular predisposing risk factors even, but usually, as my understanding, there have been predisposing factors that would explain that to some extent.
Thank you. You mentioned, I think, at the outset of your evidence today that Dr. Tegnell had co-authored a paper on the effect of school closures on the spread of infection, which focused on European settings, as he said. And he goes on to say that he and his colleagues, and they were colleagues from other countries, that he and his colleagues found that school closures do not have any definitive benefits when it comes to containing a pandemic. On the contrary, they had a number of potentially negative consequences. Now, taking that in stages, Dr. Croft, that article and that work done by Dr. Tegnell obviously focused on European settings. And its conclusion was that there was no definitive benefits when it came to closing schools. As a public health expert and epidemiologist, would you have wanted or wished to see some sort of assessment of that potential when schools were closed in Scotland?
I would have wanted to see some kind of formal evaluation of the presumed benefits and the likely risks, the likely harms that would result from a policy as dramatic as closing schools, because that is something that hasn't happened in living memory, as far as I can recall. And whether there was such a formal risk and harm and benefit evaluation carried out prior to the policy being introduced, I don't know.
Yeah. Well, we'll no doubt hear about that.
Yes.
What he does talk about are the number of potentially negative consequences. The obvious negative consequences that children are not in school.
Yes.
But he also goes on to talk about others. So, and we've heard again about this particularly from groups representing women in Scotland, that children who were required to stay at home because their schools were closed could be exposed to violence, either physically or simply seeing that violence perpetrated on usually their mothers because of this. Again, is that something that if you were factoring into a decision on whether to close schools, you would have had regard to, from your perspective?
Right, it wouldn't be the first thing that would spring to mind. The point being that the mothers would be frustrated at being at home. Is that what would cause
I think the opposite would probably be the case, that the mothers might be forced to be at home by coercive partners.
Right. Okay. Well, yes, but the thank you, Mr. Gale. The immediate harm, as I see, would be to the children themselves, whose learning would suffer, even if assuming they had access to remote learning. It's not a substitute for learning in a classroom with a teacher, I don't think. Educationists might think otherwise. So the children's learning would suffer. The nature of their development, human development as individuals, would suffer, because we are social animals. It's in our nature to be sociable and to have interaction with other human beings, not with screens, and then the whole nature of the problem would be rather frightening for children. I suspect they would feel that the world was coming to an end, and so therefore there would be this general sense of doom and fear that would be inculcated by a school closure. And then there would be the economic considerations, where the parents would have to, somebody would have to stay at home and look after the children. Well, it could be the grandparents, but it would more likely than not be one or other of the parents, perhaps both taking it in turns, and that would have economic consequences which would lead to greater poverty, and would lead perhaps to domestic violence and frustration. So the whole as a policy, it would have potentially very grave consequences, not just educationally but societally, which would persist to indefinitely, because missing out on education has a very long-term impact, has an irrecoverable impact on somebody's ability to grasp the nature of what it is they're supposed to be doing. I can remember going to the dentist from school and missing a morning in which was biology, and to this day there's that bit of biology I don't fully understand, because I missed the key class about it. So missing a whole year or year and a half of school would be very, very gravely damaging, I think, for children's development. And it may be that educationists have advised the inquiry as to the long-term effects of that.
Thank you. I'd like to ask you a little about self-isolating and the advice that was given in Sweden by Dr. Tegnell and his colleagues.
Yes.
And that's referred to at page 126 of Annex B. And I think we see at the beginning of that Dr. Tegnell, as he puts it, turning something around, which was the vague sense of feeling unwell, and saying to the population of Sweden, quote, "It is vital that everyone acts responsibly and stays at home if they are not in good health." And he then follows that by talking about the Swedish practice of voluntary action and individual responsibility, rather than mandating fixed rules. And he says, "We wanted to protect Swedish citizens in a lasting, sustainable way. The measures that we proposed had to work for our diverse society, from densely populated Stockholm to sparsely populated Norrland. I am a firm believer in this approach rather than the one-size-fits-all." The one-size-fits-all is an expression we've heard in this inquiry on numerous occasions and in several contexts. Could you comment on what Dr. Tegnell says there, please?
Well, yes, of course he's coming from a different sort of society, but they're not that different to our own. They're Europeans, they're educated, they know something about science, they practice hygiene, domestic hygiene, personal hygiene. So this isn't a completely different culture to our own, and if they can embrace this responsible approach to a national emergency, which they did, and they sustained it to the end, I don't see how it is that we in Britain couldn't have done the same, given the appropriate guidance and the appropriate support and the appropriate information from our policymakers.
The element of diverse society that he refers to is a contrast between the densely populated urban areas of Stockholm to the less densely populated, indeed sparsely populated areas of Norrland, which I think is north of the Arctic Circle. And he refers to that again in the next passage, where he talks about regionally adapted measures. Do you see that as being something that there might be some benefit in having individual I wouldn't say lockdowns, but individual non-pharmaceutical interventions, standing the different areas in which one is dealing with?
Yes, well, we sort of introduced something like that because there was a tier system where different parts of the country were in different tiers. I remember Manchester being worst tier for quite a long time, which caused them grave upset, quite rightly. So we did have something of that kind, but obviously it wasn't as sophisticated as it seems to be described here. It was much more broad brush.
Thank you. Again, picking up in the next section of Dr. Tegnell's memoir is again something that we've heard about on a number of occasions, and that is the use of the expression an abundance of caution. And this is in on page 127 of what we're looking at. And he's talking there about, he poses, I suppose rhetorically, is Sweden not known for its prudence and circumspection? And what happens to a society that is forcibly locked down and cordoned off? It says, rolling out of strict measures and saying that one is doing it out of an abundance of caution is easy. But I consider that this is a sloppy interpretation of the precautionary principle. And I'd just like to ask you a little about that, because that's, again, an expression we've heard, and it's posed directly to you in one of the questions.
Yes.
The precautionary principle. So far as you and as a public health expert and an epidemiologist, what do you understand by the precautionary principle? Because it applies in very different fields, and we all know it perhaps in fields that we've practiced in, and it has a very different connotation. What do you understand by the precautionary principle?
Yes, it does come up in public health publications. It's not a principle I remember being formally trained in, so I've always assumed it's just been borrowed from the field of law. But what I understand it to mean is that if you're faced with a threat and there's a set of reasonable measures that you can use to mitigate that threat, then as a precaution, even though the threat may not be immediately present, those measures should be considered and perhaps applied, as long as they themselves are not going to be so harmful as to make them as to be injurious. That's my understanding of the precautionary principle. So perhaps seatbelts come under that principle, crash helmet wearing. There are people who would argue that crash helmets should not be compulsory for motorcyclists because it's up to the individual as to whether or not they feel they're at risk, but as a precaution, because it doesn't carry significant harms, perhaps impedes ability to, as a precaution, most countries, not all countries, have introduced compulsory crash helmet wearing on the precautionary principle. That's how I understand it as a public health physician.
I'm just interested, Dr. Croft, in your comment on what Dr. Tegnell says there, where he refers to an abundance of caution is easy to say. But he says, I consider this a sloppy interpretation of the precautionary principle. What do you understand by that?
Yes, well, he says earlier how he's had discussions with ambassadors and public health experts in other countries, and I dare say that the discussions were often quite challenging, and he was perhaps, we'll be able to find this out on Wednesday, and this word, the precautionary principle, was thrown at him. Well, surely on the precautionary principle we should lock down, we should close borders, we should have face mask mandates, and so Dr. Tegnell has reflected on this, and he said, well, no, because the precautionary principle isn't a carte blanche to apply all potential mitigatory measures. It should be applied prudently, and as long as the application of the principle doesn't bring in its wake its own harms, its own potential damage.
You say prudently.
Prudent, yes.
Would it not be better to put it, having considered to a reasonable degree all other scientifically based knowledge? Yes.
So he obviously does know about schools and school closures. So from the outset he was not going to apply the precautionary principle in the context of closing schools and other areas where the precautionary principle might have been invoked in other countries. He just adopts a higher bar to apply them. Is how I read his comments about the precautionary principle there. And we may come on to discuss what Dr. Ioannidis, he also talks about the precautionary principle. He's quite dismissive of its of people invoking it in order to justify measures that are very extreme. So it's not a wrong principle, but it needs to be applied with discretion and prudence and with the benefit of science.
Yeah.
Can I go to page 128 in the annex to your report and look at the subject of face masks?
Yeah.
I think this is, again, quite an important area, and we will touch on this quite directly when we come to some of the questions that have been posed for you. I suppose I can begin by saying to you, it is difficult for a non-scientist and a non-expert within this field to get out of their heads, and I include myself in that, the idea that if I wear a face mask, that it is of some benefit to me, and in the course of the pandemic, which I did. Now, what Dr. Tegnell says that he did, or he and his colleagues did, was trawl through academic studies for evidence to support a particular approach. And he says, most studies on the wearing of masks related to incidences of respiratory disease before the COVID pandemic. From the available scientific research, it was impossible to conclude that face masks had an appreciable inhibitive effect on the spread of infection within the society. Now, that's probably a generality, but picking apart that generality, are there points within that with which you agree or disagree?
I disagree with his. I agree with his point in principle, and later on he comes back to face masks later on.
Yes.
Perhaps we'll come there, but of course he's really referring to non-medical settings there. Perhaps he doesn't make it entirely clear. So face masks will help to prevent infection of all kinds in medical settings, and that's why surgeons wear them and have always worn them for carrying out operations, and nurses, for example, will wear them if they're changing a wound dressing. But here he's talking about the population as a whole, and he says face masks do not appear to have an appreciable inhibitory, I think is what is meant there, effect on the spread of an airborne infection within the population as a whole, and that's the message of studies that at this point in time that seems to be the case. Later on, later on in the pandemic, there were, of course, a couple of randomized controlled trials that explored this actual question, and they seemed equally to not demonstrate that face masks in non-medical settings had any significant effect on slowing the transmission of COVID-19. That's the Danish study and the Bangladesh study that we talked about when we last met.
Yes.
Yes.
Thank you. We'll maybe come back to face masks in we'll certainly come back to them in the context of direct questions that have been put for you. I'm going to pass on to what is said at the bottom of page 128, and this is said by Dr. Tegnell in the context of a meeting that he had with our then Prime Minister, Boris Johnson. There's a lot of interesting anecdotal comment in there, but there are one or two things I'd just like to ask you about, because I think this has a connection with the paper that you've referred us to, the Ioannidis paper, in relation to forecasting. And if one goes to page 130, there is a reference there to the, I think by now well-known predictions of Professor Neil Ferguson. And in the middle, just above the middle of this page, Dr. Tegnell refers to the model insofar as it was applicable to Sweden, as creating what he describes as a nightmare scenario. And if it goes to the previous paragraph, he says that Ferguson's model threw up startling figures that caused consternation worldwide. It predicted that up to 250,000 people in the UK would die of COVID-19, and that the health system would collapse unless strict measures were introduced. He then describes that as the nightmare scenario. And he then says that he read that, but with a certain skepticism. And he goes on to explain the reasons for that skepticism in the succeeding paragraphs. Can I take you back to that time when that forecast was given, and we are all aware of it. As you, as a public health expert and epidemiologist, did you harbour the same skepticism as Dr. Tegnell?
Well, yes, I did, and that's partly because I, in common with other public health physicians, were aware of the track record of Imperial College in making, in modelling for various diseases, and that went back to Jakob-Creutzfeldt disease, mad cow disease in 1995, when they predicted that thousands of people would acquire this condition. They didn't. And then there was foot and mouth disease, which I wasn't involved in because it's an animal disease, and 1 million cattle, I believe, were slaughtered because of the Imperial College prediction. And then notably, and I was involved in implementing the recommendations at that time, were the 2009 to 2010 swine flu pandemic, which fizzled out very quickly because it just burnt itself out. The predictions were for 10,000 deaths or something, and then in the end there were 400. So their track record wasn't good. So I was surprised that this particular group of modelers were being, yet again, invited into the arena, when there were other modelers who had, it seemed to me, far less draconian or far less gloomy predictions, who were not given the same credence or simply were pushed aside. And so, yes, so I was sceptical, yes.
Well, by my watch, it's 11. I think I may be slightly running
I think the
ahead.
inquiries clock is slightly different, but we'll not dispute.
We will not dispute. Thank you.
We'll take a break now. We're required to for the stenographers, apart from anything else. We'll come back at 11:15. Thank you all.
All right.
Right. If you're ready, Dr. Croft.
Yes.
Good. On you go, Mr. Gill.
Thank you, my lord. Dr. Croft, I realised there was one passage that I didn't ask you to comment on. I just simply flicked over it. Could you go back to page 126? Or could you be directed back to 126? And this is Dr. Tegnell talking about overarching objectives. And he says that Sweden's coronavirus strategy, published by the government in early April 2020, set out 6 key objectives, and he lists them. First, to limit the spread of infection within the country. Second, to safeguard resources for healthcare services. Third, to mitigate the impact on critical jobs. Fourth, to cushion the blow for citizens and businesses. Fifth, to keep any public agitation caused by the spread of the virus in check. And sixth, to implement the right measures at the right time. And he goes on to say, as I saw it, these points, born of prior consideration and experience, provided a useful guide. They signposted a path that appeared to deviate sharply from that taken by many other countries, which sought to halt the spread of the infection at any price, no matter how high. And he gives the examples of Australia and New Zealand, which poses an interesting potential for our discussions on Wednesday and Thursday of this week. Again, could you comment, Dr. Croft, on your perspective of those objectives, and in particular his comment that they were born of prior consideration and experience?
Yes. Well, it's admirable that there's a range of objectives, and I guess the experience he's talking about is experience of swine flu, avian flu, which was another potential pandemic that never happened, and Jakob-Creutzfeldt disease. I guess that's the experience that he's talking about. But he's presumably alluding also to his experience of having studied schools and noted how closing schools wasn't a solution to limiting the spread of respiratory viruses. What I haven't established is whether there was something comparable range of objectives in the UK or the Scottish government approach, because that's not something that ever came up in any of the publications I refer to. I did in my report refer to the aims of the vaccination programme, but of course that was quite the 3 aims. That was quite a long way down the line. Yes. So, yes, the objectives look reasonable and comprehensive and interesting. The safeguard resources for the healthcare services. We sort of had that, didn't we? We had Save the NHS, which meant save the NHS by not using the NHS, but that had consequences further down the line where people had to race back to the NHS to have their chronic complaints dealt with.
What I'm particularly interested in, Dr. Croft, is Dr. Tegnell's observation that, and looking at the way in which the Swedish strategy involved was deviating sharply from that taken by many other countries, which sought to halt the spread of the infection at any price, no matter how high. Now, reflecting on that, can you understand what and give a view on what Dr. Tegnell is saying there?
I have to say,
obviously leaving it to Dr. Tegnell to give his own view.
Yes, I'd say I'm on the side of Dr. Tegnell, because there has to be a price that is too high when it comes to limiting the spread of infection. As long as the spread can still be achieved by measures or a group of measures that are proportionate and carry with them relatively little collateral damage, such as socially distancing ourselves in a voluntary way and washing hands and so forth. So that I think is what he's saying there, that there is a price that's too high in terms of limiting the spread of infection, and he and his Swedish colleagues chose not to go down that route.
Yes. Looking just at the aim to halt the spread of infection, let's take out at any price. Look at the spread, halting the spread of infection. In the context of what Dr. Tegnell has said, and some of his observations on geographic differences and diverse society, do you take from that what he may be saying, and I hesitate to say what somebody else is saying and put it to you, but that he may be referring to the targeting of measures specifically to halt the spread of the infection?
I take it he's surely referring to measures that are extremely coercive, which we may come on to discuss later with our second authority. Okay. That's so he's in his mind he has a dichotomy of reasonable measures and then non-reasonable measures, extreme measures, and he's and within discussion with his colleagues and looking at the literature, he's mentally putting the various measures that can be taken into either of those categories, and there's some certain grey area in the middle where there's some room for manoeuvre. But in his mind, he's pretty clear as to what is reasonable and what isn't reasonable. Yes. It seems to be from the outset of the pandemic, based on previous experience and the body of knowledge that is available in the scientific literature.
What I'm particularly focusing on is perhaps geographic targeting and/or targeting particular sectors of society who may be particularly vulnerable.
Yes.
Do you see
yes.
Purpose in that?
Yeah, certainly. Yes. And well, as we were saying, the tier system was sort of geographic, wasn't it? Well, which was adopted in Britain, but there didn't seem, well, of course there was advice for the vulnerable sectors, but to some extent that had been the care, or should we say, the responsible approach to the vulnerable sectors could have been adopted very early on, but to some extent they were thrown to the winds by the policy of discharging hospital patients into the care homes.
Yeah. Now, there was one other passage that I did slip over.
Yes.
And that's at page 127, and that's in relation to disinformation and speculation, particularly online. And I think Dr. Tegnell, and we will hear from him obviously, there was a concentration, as he said, on making our information as clear and accessible as possible.
Yes.
All the while we have the compliance of Swedish society at large in our sites. We wanted to make sure that people were following our recommendations and principles. Of course, adherence changed over time and it remained high throughout the pandemic. Generally speaking, Swedes did not seem particularly susceptible to disinformation, at least compared to countries like the Netherlands or Germany, where starkly polarized views emerged. Now, this is maybe something beyond your ken, Dr. Croft, but can I just ask you about, from your perspective, the question of disinformation and conspiracy theories, etc., that were put on social media and otherwise online. Do you have any comment to make about that?
Well, of course, I'm not on social media in any capacity, so I wasn't involved in any of that. But one couldn't help but be aware that there was a range of opinions being expressed on social media. Some of them quite extreme, and they ranged from the origins of the virus, where it came from, and to opinions about different types of treatments, that some of which were surprising, and then opinions about the measures that were being used, taken by the government. So in an open society, I guess we have to allow a degree of debate on social media and in public fora about what our policymakers are doing. So there has to be some debate, but how to control that debate is always going to be difficult because people don't like to be censored. And I'm interested to hear Dr. Tegnell say that in Sweden people were naturally rather sensible, so that may be a reflection of their kind of Nordic temperament.
But it is, in fairness, out with your knowledge.
Oh, okay, right. So that's my knowledge. Actually, I was in Sweden in the summer. I went to a scientific conference where I thought it was about infectious disease, and I thought COVID would be discussed, but it wasn't particularly, because it's still the knowledge is still gradually, slowly being added to. And I talked to a Swedish public health physician about the position they'd adopted, and he told me Dr. Tegnell had recently retired, and he'd been a colleague of his, and he said not everyone agreed with Dr. Anders, but he said he explained his positions very well, and people accepted that he was explaining them, and so therefore the public, I think, had trust in him, and that's perhaps why they didn't use his colleagues and the public had trust in him, and that's why the Swedish people at large didn't fall victims to the more extreme type of comments that were seen in other countries.
Okay. Could we go back to where we were before the break?
Yes.
And that's it, looking at forecasting. So if we go to page 130, please. Now, I'd asked you about whether you shared the scepticism of Dr. Tegnell. I think you've indicated that you did. And I'd like to just be clear about what is said by Dr. Tegnell on the range of variables that can be used in the context of forecasting.
Yes.
And we'll probably come to this in a little more detail when we look at the Ioannidis paper.
Yes.
But it may be just a useful way into looking at this. This appears to me, at least, to suggest that modelling should have, or could have, I'm probably better putting it as could have, variables considered which would have involved matters such as, if I can put it generally, the downside of measures such as lockdown.
Yes.
Now, again, is that something that you can comment on, or do you feel able to comment on?
It's surely the variables, he's talking about variables like the case fatality ratio. I think that's,
yes.
He's talking about the mathematical, raw mathematical figures, I believe, that make up models. That was my understanding of what.
I think, just cutting across you, I apologise. I think he also says that towards the bottom of page 130, levels of social contact, demographics, and the general health of the population all play a role.
Oh, okay, yes.
And he goes on, as does chance.
Okay, yeah. Yes, I see, yes. So some of the variables will be a calculation as to how often a person will encounter another person face to face. That will be a variable that will be incorporated into any model of disease progression, and that can be predicted, I guess, but equally it can be altered by people altering their behaviour. So some of the variables can change with time, others will remain fixed. And when there are a lot of unknown variables and the range can be quite wide. The nature of the model will be to overpredict the consequences of a particular infection. When the nature of the infection is well known and the nature of human behaviour can be anticipated, the models will be more accurate.
Thank you. What he does say is that the types of models tended to split into two camps. This is the bottom of page 130.
Mm.
Some academics were fervent believers in the models, even for the early variants. Others were more circumspect.
Mm-hmm.
The FHM team belonged to the latter camp.
Yes.
We saw the models as tools, but were somewhat skeptical about how their accuracy in relation to the early variants of the virus.
Mm.
And he goes on to say that it was no surprise to us that the quantity of data was not sufficient to draw upon at that point. Now, I suppose what he's talking about is very predictive modelling at the outset of the pandemic, where there wasn't the level of data that probably, I'm not purporting to be any expert, but some maybe 1 or 2 months into the pandemic, there would be data which could inform the model as it would progress. Now, would you see this process of modelling as being an ongoing process?
Yes, it should be dynamic, and the models would need to be adjusted as the knowledge of the pathogen became more precise, instead of the model being applied and rigidly adhered to without necessary adjustments being made to the model.
Right.
There was a phrase in my original report that I'm trying to think where it was, but I was quoting a venerable Swedish epidemiologist called Johan Giesecke, who, in fact, I believe was Dr. Anders' mentor and predecessor in the role. And I included a phrase there saying models can be useful, but they can have a degree of spurious certainty. I think that's the phrase. I was quoting from Giesecke's book, and that I would adhere to that point. Yeah. So the Swedes clearly are rather cautious about the over-reliance on models.
What Dr. Tegnell does do is to look at, in very general terms, two types of models.
Yes.
The Imperial College one was one, and then he refers in the middle of page 131, just above the middle of it. Another type of model looks at the past and examines developments over the last 4 weeks. It then draws upon this information to extrapolate how the next 5 weeks might unfold. This type of model takes account of associated factors like immunity with a population and the rate of vaccination, so obviously looking for much further down the line. And it says that the FHM was predominantly using the latter type of model. Yet the results of such models did not provide the explicit basis for decision-making about restrictions, as again we had our doubts about the reliability of the data. Do you have a comment on that?
Yes, so clearly they were using a more dynamic model that was rather restricted in its scope to deriving the determinants of the model from the previous 4 weeks. But even then, they only used it as a guiding tool, not as a set of rules that had to be followed slavishly. That seems to be a sensible approach.
I think I can probably pass over a little bit on the next section, but if this passage that we quoted involves both his dealings with the UK Prime Minister and his advisors, and also dealing with the ECDC, which I think is the European group. and I think we can see the ECDC grossly over, this is the top of page 132, grossly overestimated the spread of infection in Sweden and predicted that it would rise to extreme levels, and that, as Dr. Tegnell makes clear, didn't happen. And going on in that section, he says towards the bottom of the page, 3 paragraphs from the bottom, the whole episode demonstrated just how difficult this kind of work can be. To create a model, you need to know the population and the context, and you need accurate data besides. Yet despite its obvious deficiencies, the Imperial College model enjoyed unprecedented coverage. I take it you agree with that?
Yes.
And it said, according to its calculations, Sweden would be admitting 16,000 people to intensive care every day in spring 2020 if we did not introduce harsher restrictions. Today we know that a maximum of 550 people were treated in intensive care wards on a daily basis at the height of the pandemic in spring 2020. Now that, I think, is something we also see in some of the examples given in the Ioannidis article, and in particular in relation to some of the states in America. I think examples are given of New York, Tennessee, and California in that paper. So, again, do you have a comment to make about the fact that the predictive calculations were considerably out of line with the reality that was experienced?
Well, yes, and some epidemiologists were saying at the time that the nature of respiratory viruses is to dramatically decline in the warmer weather anyway, and therefore one shouldn't be too concerned about seemingly exponential spread in February and March. That's just what we see. That pattern happens with seasonal influenza every year. It hits us badly in November to February, and then just pretty much dissipates. So it may be that the models that were being used weren't really taking that sufficiently into account, the natural seasonal flattening of the wave that would occur simply as the spring turned into summer, and they were anticipating that the rate of spread of the infection would continue regardless of that climatic effect. And of course we had a particularly mild spring in Britain. Whether they did in Sweden as well, I don't know.
Right.
I'm so sorry. There was a little phrase that I spotted now, which is interesting. Page 129. This is Dr. Tegnell, who was directly privy to this meeting with Boris Johnson, and he said that the scientists, next was the scientists tend to speak, and they were talking about a circuit breaker lockdown. Yes. So clearly, it was put to the Prime Minister that a lockdown would immediately cause and dramatically cause the infection to fall off a cliff within a couple of weeks. So there was a circuit breaker. That's what I understand by a circuit breaker. But obviously that didn't happen.
Thank you. I think I'll leave aside the remainder of Dr. Tegnell's reflections on that meeting. Yes. Going back to a circuit breaker lockdown was, I think we know that was discussed. To your knowledge, did it occur in Scotland, or was it, or in the UK, was it effective?
Wasn't that that's right. So this meeting was taking place in September 2020. So there was a lockdown in November, The whole of November there was lockdown. So this was, again, they thought, well, we'll have a lockdown and then we'll completely interrupt transmission. But there may have been some impact from the lockdown. But I just think it's an interesting concept that this is how lockdowns are viewed, as somehow completely cutting the ground from under the feet of the virus, and yet that wasn't the reality as far as I could see. There was,
and with a drag of time.
There would be a short interval.
Drag of time. There would be an interval before it became effective.
Exactly.
But the level of effectiveness would be high.
Yes, after the latent period of a couple of weeks. Yes, it would be dramatically high. It would be breaking the circuit, which is like going from, that's an electrical metaphor. So you go from having your lights on to having no lights on at all.
Now, as I say, I'm not going to go through anything further in that section. We can see that Dr. Tegnell did, I think, question as to why he was at that meeting. And that he says that he did not believe that there was any realistic chance of persuading the Prime Minister, even though that had not been his intention to follow what Dr. Tegnell was saying. I think we can find that at the bottom of page 133. Can I move over to page 135, please?
Yes.
And that's in relation, we're coming back now to the effectiveness of face masks. And I think Dr. Tegnell observes that many Swedes sought out protective measures of their own accord. Some isolated it completely, others wore face masks, although we had never recommended this ourselves. In the context of the pandemic, does that surprise you that there wasn't a recommendation on face masks?
Well, again, I think what he means is that we hadn't recommended it as necessarily going to be helpful in contexts outside of hospital or nursing home care. That's what I think is meaning there.
Yeah.
But because there was the scientific evidence, such as it was, didn't indicate that there was any benefit to be obtained from wearing face masks in those environments. Perhaps even contributed to the spread of infection if they were not being worn correctly.
Yes. And I think that's reflected in what he goes on to say. And he's referring to autumn 2020,
yes.
When there was a rise in the number of cases. And he poses the question, why not make it compulsory to wear a face mask, even if it only had a minor effect? There was nothing to lose, right? And I think that probably reflects the questions that a lot of people would have been asking at the time. And he then expresses his view fairly clearly and to the contrary. He says, I believed we did intend to have something to lose. To my knowledge, no one doubts that masks are effective if used correctly, but I was certain that they would not be used. Correctly. On my travels, I had observed people treating their masks carelessly. That was completely understandable. Wearing a mask is annoying. My observations were merely anecdotal, of course, but they were in the back of my head, along with the research papers that I'd read. Is that, again, sort of, I know you're not very keen on anecdotal observations,
Yes.
Dr. Croft, to inform the science, but is that something that you would have been aware of?
Yes, well, he's clearly being pressed on the basis of the precautionary principle on this matter, and the arguments that plainly were being put to him was, well, why not have masks on the precautionary principle? Because there are no downsides. And he says, well, hold on, there are downsides. And he talks about the infection downside, which is important. but actually there are downsides. He doesn't even mention, like the cost of masks, the plastic, microplastic pollution of the ocean. They mentioned the Cochrane Review as in throwaway, and the inability to communicate with your loved ones, and other people, that the masks impose the sort of uniformity of thinking and lockstep that they impose. So there are societal and psychological downsides to mask wearing that it doesn't allude to there, but other commentators have majored on.
Yes. I think one of the issues that we've heard about in the inquiry, and I'll just put it out there for you to comment on in this context, is that if one is dealing with a patient who is has some form of mental compromise or something like dementia in a care home, finding somebody wearing a mask and treating them, and indeed all the other accoutrements of PPE, might be distressing. Is that something you would have in mind?
I'm sure that's the case, and people at the end of life will have difficulty recognising even their own sons and daughters, and if they're wearing a mask, it makes it even more difficult and frightening for all concerned. So, at that, in that setting, there are particular, special, unique downsides to wearing a face coverings that ought to be factored into in any face mask mandate.
Thank you. Can I pass on, and I'll leave vaccinations to probably to Mr. Edward in dealing with, but can I pass on to post-pandemic reflections that Dr. Tegnell refers to it, page 137. And I think this is probably worth reading in its entirety, because it does pull together several of the threads that we've been discussing this morning. The first is that Swedish citizens trusted the authorities and largely adhered to the recommendations of the health authority. Many made adjustments to their day-to-day lives by working from home so as to mitigate the spread of virus. There's then some data from the Swedish mobile network provider to indicate the movements. And he says that the accompanying graph to that data took his breath away. It clearly showed immense efforts that the Swedish people had gone to combat the pandemic, and that we had fought our way out of the crisis together without ever having to use force. Can I have your reflection on that, please?
Yes, it's of course in our country we did have to use force. The police made many arrests of people who were breaking the regulations, and draconian fines were imposed. I think the fine for not wearing a mask on the underground rose to £2,000. It was of that order. So we perhaps have a lot to learn from the Swedish people who didn't have to resort to those measures.
He goes on to say that public life went on more or less as usual during the pandemic. The decision not to impose lockdowns may well have reduced the risk of depression and other adverse effects on health associated with self-isolation. Now again, this is something that you referred to in your first report, and we discussed in your presentation in Dundee.
Yes.
This is again being, to a certain extent, being reiterated by Dr. Tegnell. As a public health expert and epidemiologist, should or could the potential effects on mental health prior to announcing a strict lockdown have been taken into account?
Yes. obviously mental health is to a very large extent determined by one's natural resilience, but also one's interaction with people around one, whether at work or at home. And increasingly it's recognised that one of the determinants of longevity and good health in older age is the social networks, that's a good jargon phrase, social networks that people have, and health professionals say, well, so-and-so is being discharged home and he's got good social networks, meaning that his prognosis is going to be good, and he or she will have a good quality of life at home. So a lockdown immediately cuts away all of that social network dimension of health. It just blocks it out, and mental health will suffer, as also will physical health, and that certainly should have been factored into lockdown planning.
Thank you. He goes on to reflect, and these are some of his thoughts on the matter. He says, there was no real debate on an international level about potentially negative consequences of protective health measures. For our part, we put forward arguments to explain why we were not enacting more regulations. It is worth bearing in mind that in many countries there was an enormous political pressure to introduce strict measures quickly. As I see it, this pressure left no room for counter-arguments. Now, I suppose this is straying a little into matters of politics, but and political comment. From your perspective, did you find yourself, to the extent that you were at odds with what may have been happening?
Well, yes.
Did you find yourself feeling that you were something of an outlier?
No, I felt I was at all times in line with the best evidence that existed, which is what I cited in my report, and have also alluded to in my responses to the questions, my supplementary report. So I don't consider that I was ever an outlier, and I'm not now. But the way the public opinion was shaped to a large extent by the media, was that we were heading for extinction as a race. That was pretty much the bottom line, and therefore the most dramatic measures were needed to avoid that catastrophe. That was, I think, what a lot of people were feeling, and that was perhaps should have been countered more vigorously by politicians. It was to a large extent the media who like to scare people, and people like to be scared. So there was a degree of collusion between the public who wanted to be scared and the news media who wanted to put out horrific stories. So that didn't leave a lot of room for manoeuvre for the politicians in Britain. But the same stories were circulating in Sweden, no doubt, and those epidemiologists advising the politicians encouraged them to resist the doomsday scenarios. That seems to be the difference between them and us.
Thank you. Just the final passage from Dr. Tegnall's memoir that you've quoted here is, again, Post-Pandemic Reflections. And he talks about communication. And he says, communicating something like this is far from easy. No one wants to hear that all these dreadful happenings, deaths, sickness and restrictions are going to go on for several years. We tried to be transparent about probable time frame, and whilst also coming up with measures that people could live with and uphold for a long time to come. Working from home and staying in while you were feeling ill is, in my view, and presumably the view of many others, an easier prospect than being compelled to stay inside with your front door nailed shut. Perhaps a slightly dramatic way of putting it, but yes. Do you agree with the sentiment behind that?
Yes, I do, yes. Yeah. the key word there is compelled. And we were compelled in Britain under threats of severe fines and imprisonment even.
Yeah.
Right. Dr. Croft, can I now pass from that to the paper that you provided us with from the International Journal of Forecasting, just to remind co-participants, this is SCI EPB 000014. Now, this is a paper by, as I've said, Professor Ioannidis, Professor Cripps, and Professor Tanner. Ioannidis and Tanner are both based in America. Cripps is based in Australia. And some of what we find in here has already been heralded by some of the discussion we've had this morning. But I wonder if you could just look at the abstract, first of all, from that paper, and read it. It's probably the easiest way to do this. Read it out, and if you feel you want to pause at any stage during it to reflect on what is said in that abstract, can you do so, please?
Yes, of course. Abstract. Epidemic forecasting has a dubious track record, and its failures became more prominent with COVID-19. Poor data input, wrong modelling assumptions, high sensitivity of estimates, lack of sensitivity would be high sensitivity would be lack of precision, so having very broad estimates, very. So high sensitivity estimates, lack of incorporation of epidemiological features, poor past evidence on effects of available interventions, lack of transparency, errors, lack of determinacy, not quite sure what that means, lack of determinacy, consideration of only one or a few dimensions of the problem at hand, lack of expertise in crucial disciplines, groupthink and bandwagon effects, and selective reporting are some of the causes of these failures. Nevertheless, epidemic forecasting is unlikely to be abandoned. Some, but not all, of these problems can be fixed, and very helpfully, I think, this team provides some fixes for nearly all of these problems in their table 1 of the paper. And they go on to say, careful modelling of predictive distributions rather than focusing on point estimates, by which they mean, I think, flexible modelling as opposed to a fixed and unvariable modelling, flexible and dynamic models, considering multiple dimensions of impact and continuously reappraising models based on their validated performance may help. If extreme values are considered, extremes should be considered for the consequence of multiple dimensions of impact. That, I think, is referring especially to lockdowns. So you've got to consider what are the worst possible consequences of this extreme measure that you're considering. Extremes should be considered for the consequences of multiple dimensions of impact, so as to continuously calibrate predictive insights and decision-making. When major decisions, e.g. draconian lockdowns, are based on forecasts, the harms, in terms of health, economy, and society at large, and the asymmetry of risks needs to be approached in a holistic fashion, considering the totality of the evidence.
Just pausing there, 2 words do slightly leap out from that passage. One is groupthink, and the other is the bandwagon effects.
Yes.
And I know that the authors of this paper go on to refer to that as we go through. What do you understand by groupthink and bandwagon effects in this particular context of forecasting?
I haven't heard of the word bandwagon effects, but I presume he means jumping on the bandwagon.
Yes,
so I suspect he's critical of his colleagues, who are all generally adopting a similar approach to the problem, and it's a major problem. It's an international emergency, and they're taking. It seems to be apparent from what he says later on that they're going down the route of the worst possible scenario, and they're taking the view that any measures to avert the worst possible scenario are justified, regardless of the cost. That's my understanding of what he's saying there. And they're all thinking that, nearly all of them, apart from some exceptions, and it's not an appropriate approach in the light of past experience with previous pandemics or likely pandemics.
I think it's interesting if one goes to the substance of the paper, the initial position. The authors say that COVID-19 is a major acute crisis with unpredictable consequences.
Yeah.
I don't think there's any doubting about that.
Yes, but of course the problem is that people were making predictions and sticking to those predictions, and he says you have to make some predictions, but they have to be flexible and amenable to change in the light of knowledge as it becomes available.
Well, I suppose what he goes on to say, or they go on to say, is that really in notwithstanding the best efforts of modelers and the use of highly sophisticated tools, forecasting efforts have largely failed. And that's in the first full paragraph of the text. And they go on to refer to the some experienced modelers drew parallels between COVID-19 and Spanish flu, which hit after the First World War.
Yes.
And I think you already made reference to this earlier in your evidence today, where that was a pandemic that caused in excess of 50 million deaths, with a mean age of death being 28.
Yes.
I think you've made that. We all lament the current loss of life. However, as of June the 18th, I think that is of 2020, the total fatalities are around 450,000, with a median age of around 80, and typically multiple comorbidities. Again, is that accord with what has been a line taken throughout your evidence?
Yes, that it does. Yes, and I only really came across this paper a few weeks ago. So it was published in 2022. So I was quite gratified to find that it was, or my thinking was on the same lines as these three authors, who, as I said, I don't know them personally. I'm skeptical. So sorry, I'm skeptical about the Spanish flu numbers. I think the deaths are correct, but I had an appendix in my original report citing modern research, which suggests that many of those deaths might have been caused by inappropriate treatments, which is why they were affecting young people. A lot of them were soldiers in barracks who were waiting to be deployed to Europe from America, and they were given over-enthusiastic treatments, and they died of what was severe flu, but they shouldn't have died.
I think if one turns to Table 1, at page 424 in the actual paper, and I'm not going to go through this in any detail with you, but the authors talk about some predictions about hospital bed needs, and they're rebutted by reality, and these are done, as I've said earlier, under reference to the states of New York, Tennessee, and California. And I think, interestingly, one can look at the prediction made in relation to New York. This is from, I think, the governor, Mr. Cuomo. Had sophisticated scientists had studied the coming coronavirus outbreak, and their projections were alarming. Infections were doubling nearly every 3 days, and the state would soon require an unthinkable expansion of its health care system. To stave off a catastrophe, New York might need up to 140,000 hospital beds and as many as 40,000 intensive care units with ventilators. That was what the politicians were being told in relation to that,
yes,
as they were recording it.
Of course, that's on 10th of April, not the 4th of October. That's the way the Americans,
yes, it is.
Yep.
It should be.
Yes.
Yeah. And then the comment on what happened. With the number of intensive care beds being used declined for the first time in the crisis to 4,908, according to daily figures released on a particular Friday, and the total number hospitalized with the virus, 18,569, was far lower than the darkest expectations. Here's my projection model, here's my projection model, they are all wrong, they were all wrong. That's Governor Andrew Cuomo quoted there. So that's one example of the disjoint between what was being predicted and what actually happened. We can look at it in the context of both Tennessee and California. I'm not going to go through those. And similarly, they provide in Table 2 a forecasting of what will happen after reopening. And again, there is a disjoint between what was predicted and what actually happened. Again, that's something we can look at. If we go to the bottom of page 425, and again, this is something you've made reference to, the authors say in the right-hand column, failure in epidemic forecasting is an old problem. In fact, it is surprising that epidemic forecasting has retained much credibility amongst decision makers, given its dubious track record. And then there's a reference to swine flu. It predicted 3,100 to 65,000 deaths in the UK. We'll go over 2 pages. Eventually, the death toll of swine flu was 457, and that's based on government data. Then there is a reference to models on foot and mouth disease, and the observation made by the authors is that scientists were challenging why up to 10 million animals had to be slaughtered. Predictions for bovine spongiform encephalopathy expected up to 150,000 deaths in the UK. I think we can see that Professor Ferguson is yes, it's the same Professor Ferguson is there. And the lower bound predicted as low as 50, which is a figure close to eventual fatalities. Predictions may work in ideal isolated communities with homogeneous populations, but not the complex current global world. Your comment on that last passage, please.
Well, I suppose that's correct. If you've got a closed community, you know what an ideal community, you know what the variables are, and so therefore your prediction is likely to be correct. An analogy that occurred to me earlier this year was that we all engage in modelling at a private level every month when we think about the money coming in that month and the money going out. We model what we're going to do with the money, and as long as we have a pretty good idea of what's coming in and what our outgoings are going to be, then the model will work and we won't get into debt. But when unexpected events come along, like the roof needing repair, then the model will break down. So I guess that's what is being said here. If in an ideal situation, a model may be spot on, but generally so much is unknown and unpredictable that a model will will fall by the wayside, and often the consequences will be very grave if government action has been taken on the basis of an unreliable model.
I'll just take you to page 429, please.
Yes.
At the top of the left-hand column, the first line of that, the authors say we need models which incorporate multi-criteria objective functions, isolating infectious impact from all other health, economic, and social impacts is dangerously narrow-minded. More importantly, with epidemics becoming easier to detect, opportunities for declaring global emergencies will escalate. Erroneous models can become powerful, recurrent disruptors of life on this planet. And I suppose I'm looking at a doomsday scenario, there it is. Now, the authors seem to be saying that these models, if they are to be of use and to be accurately predictive,
Yes.
that they should take into account what they describe as multi-criteria objective functions. What do you understand by multi-criteria objective functions in that context?
Well, criteria other than just the single one of halting the spread of the pathogen at any cost. So all kinds of economic and educational and psychological and general societal criteria would need to be incorporated in the model, is my understanding.
I suppose by doing that, one could, I'm speaking from a position of pretty much entire ignorance, but I suppose if one does that, one could at least obtain a range of predictions.
Yes, and that's, I think, what Dr. Anders Tegnell was saying just now, that it's okay to have an extreme proposal, but it should also also at the same time should be considered the consequences of that extreme proposal, including the most extreme consequences. So you could think about education, for example. Closure of schools would have, if it was going to go on for a long time, would have cause an irrecoverable damage to the education of that cohort of school children who were directly affected, and there would be a deficit there that could never be made up in any way.
So it could be made up for a population. It certainly couldn't be made up for the individuals in it, which is one of the problems.
Well, anecdotally, one heard about when children started to come back to school, there were children who didn't even know how to speak. Yeah. There were 4 or 5 year olds because they hadn't gone through that nursery phase and the phase when they're talking all the time, talking to strangers and so therefore whether that will follow them all through life is a matter for educationists.
Can I just take you on to what the authors say, and this is now in the right-hand column of page 429, and it's the last full paragraph. This is, I'll read it out for you. Blindly acting based on extreme value theory alone would be sensible if we lived in the times of the Antonine Plague, or even in 1890, with no science to identify the pathogen, elucidate its true prevalence, estimate accurately its lethality, and carry out good epidemiology to identify which people and settings are at risk. Until we accrue this information, immediate better safe than sorry responses are legitimate, trusting extreme forecasts as possible, not necessarily likely scenarios. However, caveats of these forecasts should not be ignored, and new evidence on the ground truth needs continuous reassessment. Upon acquiring solid evidence about the epidemiological features of new outbreaks, implausible, exaggerated forecasts, there's a quote back to another article by Ioannidis, should be abandoned. Otherwise, they may cause more harm than the virus themselves. Now, again, can I have your comment on really all of that paragraph?
Well, yes, this again seems to be self-evidently true. And what comes to mind is the comment that was made after the swine flu. Was it the swine? No, after, yeah. Well, no, after the 2008, 2009, 2010 swine flu epidemic, when a report was produced by Dame Deirdre Hine, and we talked about this when we last met, and she specifically warned against over-reliance on worst-case scenarios, and yet her words seem not to have been heeded, or perhaps not heeded enough in Britain during the next pandemic that came along. So that has echoes of what Ioannidis and his colleagues are saying.
Yes. Can I take you now to the section on further thoughts and to section 2.3 of the paper at page 431 in the left-hand column. I think we see here some of the comments by the authors, and they say Taleb, who's again another commentator whose papers we can see, offers several analogies to assert that all precautionary actions are justified in pandemics, deriding waiting for the accident before putting the seatbelt on, or evidence of fire before buying insurance. The analogies assume that the cost of precautionary actions are small in comparison to the cost of the pandemic, and that the consequences of the action have little impact on it. However, precautionary actions can backfire severely when they are misinformed. In March, modelers were forecasting, we've looked at this, collapsed health systems. For example, 140,000 beds would be needed in New York when only a small fraction were available. Precautionary actions damaged the health system, increased COVID-19 deaths, and exacerbated other health problems. Again, as a cautionary tale about that type of adherence to forecasting at a relatively extreme level. Do you agree with that?
Well, yes, he does give good examples of all the points he's making. His approach is coming from the North American perspective, of course, where hospitals tend to be private institutions, and they were businesses, and they were damaged in the same way as non-hospital businesses were damaged in this country. So the National Health Service wasn't damaged in quite the same way because it's supported by the government, but there was damage to our National Health Service because of the approach taken by our government.
At the bottom of that left-hand column in the final paragraph, using the seatbelt analogy, towards the bottom, the writers say, that's about 10 lines from the bottom, even before the COVID-19 pandemic, we had randomized trials. That's something that you refer to frequently.
Oh, yes, yes.
We had randomized trials showing 28% reduced odds of influenza infection with hand washing, and non-statistically significant but possible 47% reduced odds with proper mask wearing.
Yeah.
Despite lack of trials, it is sensible and minimally disruptive to avoid mass gatherings and decrease unnecessary travel. Prolonged draconian lockdown is not equivalent to seatbelts. It resembles forbidding all commute. Again, your comment on that, please.
Yes, I certainly agree with the last sentence. Where I think Dr. Anders would make, Dr. Technell would make a comment, is the point about where he says, despite lack of trials, it's sensible and minimally disruptive to avoid mass gatherings. And he actually implies that really, what is a mass gathering? Is it 4 people, 10 people, 1,000 people? So therefore, there's a need for better science to be firmer about that particular statement.
Yes. Yeah, could I just take you now to table 4?
Yeah.
And one of the precautionary actions that is said there, and it said the adverse consequences of precautionary actions, expecting excess of hospitalization and ICU needs as forecasted by multiple models. And you can just look at the second of those in the left-hand column. We see send COVID-19 patients to nursing homes.
Yes.
And then the justification of that is given as acute hospital beds are needed for the predictive COVID-19 onslaught. Models predict hospital beds will not be enough. And then the, not sure if one would necessarily agree with what's actually said in the description, what went wrong, but that's how the writers put it. Thousands of COVID-19 infected patients were sent to nursing homes, and the Associated Press counts over 4,500 virus patients sent to New York nursing homes in 2020, where large numbers of ultra-vulnerable individuals are clustered together, may have massively contributed to eventual death toll. Again, your comment on that?
Yes, of course, this is to some extent written with the benefit of hindsight, and he admits himself, but I think he's inferring that what was wrong was that the worst case scenario was being held to when it could have been, it needn't have been used to take this measure. There could have been perhaps hundreds rather than thousands of potentially COVID infections sent to nursing homes, but there was this mass stampede to empty the wards in anticipation of the overwhelming numbers that never arrived.
Sure. Again, because we're not specifically dealing, and don't have the capacity to deal with criticisms of modelling itself.
Yeah.
I think the writers of this paper do address the issue of potentially abandoning or improving epidemic forecasting. This is in 3.2 at page 432, and the right-hand column. And again, this is something I'm not going to take you through in any great detail, but in the following pages, I think on a number of occasions, the writers give some indications of how they feel that forecasting could in the future be improved, and they are not suggesting that the forecasting be thrown out of the window.
Yes. I thought it was very, very, very helpful table. It has very concrete and helpful points.
And now, can I take you to 3.3, which is learning from the COVID-19 pandemic and from our mistakes.
Yes.
In the left-hand column of page 435, where the writers say we wish to end on a more positive note, and indicate that forecasting can serve as a springboard for discussions and debate, and pass on from that. If I can go to the next full paragraph, and I'll read this to you for your comment. What we have learned from the COVID-19 pandemic can be passed to future generations that hopefully should be better prepared to deal with a new, different pandemic, learning from our failures. There is no doubt that an explosive literature of models and forecasting will emerge again as soon as a new pandemic is suspected. However, we can learn from our current mistakes to be more cautious with interpreting, using, and optimizing these models. Being more cautious does not mean acting indecisively, but it requires looking at the totality of the data, considering multiple types of impact, involving scientists from very different disciplines, replacing speculations, theories, and assumptions with real empirical data as quickly as possible, and modifying and aligning decisions to the evolving best evidence.
Yes.
Now, that to me sounds very akin to what you have been urging based on the evidence-based medicine.
Yes, yes, indeed. Yeah, it's to some extent it's a counsel of perfection, and
well, it may be.
And the difficulty, of course, is that once governments take the view that there is a life-extinguishing crisis on our doorstep, the public will clamour for dramatic actions, and they become very popular, and so therefore that's the tension that politicians have to work with. So in Sweden, going back to Sweden, they seem to have been drawn down that path, but the advice given was to the politicians was no, resist. Even though they were almost the only country to adopt that approach, even now they at least its main instigator of that approach, Dr. Taylor, still maintains that was the correct approach for Sweden. That's why he calls his title Another Way. He doesn't call it The Way. He calls it a different way, another way.
Just completing this paper, we see that it says the final full paragraph on the right-hand column on page 435. In the current pandemic, we largely failed to protect people in settings at risk. We could have done much better in this regard. It is difficult to correct mistakes that have already led to people dying, but we can avoid making the same mistakes in future pandemics from different pathogens. And I suppose one of the underlying points there is that a different pathogen may affect different generations of the population.
Yes.
It may well affect young people rather than the very elderly.
Of course, yes, indeed, it may, yes.
Yeah. And just returning to the point about young people and children, if we go down towards the bottom of that paragraph, about 10, 12 lines from the bottom, there's a sentence beginning, however. Moreover. Moreover, we know that 100,000 cases in healthy children and young adults may translate to almost 0 deaths. Conversely, 100,000 cases in high-risk, susceptible individuals and settings may translate to many thousands of deaths. That may be flattening the impact to a certain extent, but again, is that something that reflects the way in which you've approached your evidence to this inquiry?
Yes, it's adopting the principle that the one-size-fits-all approach isn't appropriate necessarily when you've got a pathogen that has a variety of impacts in different groups of the population, which SARS-CoV, when all pathogens do really, but SARS-CoV has this particular predilection for the very old and the immunocompromised and the very sick. So therefore the approach logically and reasonably and sensibly should be tailored to take into account that knowledge.
I think with that, Dr. Croft, it is 12:30. Time to rise, my lord.
Indeed we will. Rise for lunch now, we'll come back at 1:30. Thank you all.
All rise.